So our panelists, Dr. Oding will stay up there. We have Dr. Elizabeth Yu, who's a refractive and cornea surgeon in private practice. You've probably seen her face all over magazines. She's a former YO committee member as well. We have Dr. Deepa Yoganathan, who is in private practice, she's a retina surgeon. She was at Buffalo for 5 years and now is in Ontario. And then Dr. Ron Pelton, who's an oculoplastic surgeon, but also is on the AAO Ethics Committee, and he's the chair. So I think we've got a very good panel setting here. Where's Elizabeth? Dr. Yu? Got it. Cool. So let me start with Dr. Oding's video. So good outcome in the end. What do you say to the patient? Do you have to say anything about what happened in the operating room?
Well, I think you have to say, first off, in a situation like that, and also in Whitney's situation, forever, other eye doctors are going to notice that something funny happened, right? So you just have to realize that that at some point the patient's going to find out that there was a different situation. There's a different lens. The lens is placed in a different position. So just get rid of any notions or sort of notions in the back of your mind that I can cover this up. Okay? So you just can't cover. You can't cover it up, and you shouldn't cover it up. So don't even think about covering it up. Okay? I think in my opinion, there's 3 phases of that communication. And Steve and I were just talking about this. The first phase is right at the time of surgery. I think you have to say something to the patient that we've had a little issue with the capsule. We're going to take care of it really quick. We've got all the right equipment. We've got all the right things for this to happen safely. I don't want you to worry about it, but you may hear some different things than you did with your other eye, or you may notice something different than you did with your last surgery. I think the second phase of the communication is right after the surgery, where you go into the recovery area, you sit down, you got to sit down, and you look the patient in the eye and you say, I'm sorry, we had a problem with your surgery. The little thin capsule, sometimes they'll say thinner than a red blood cell, the little capsule tore, and we had to put your lens in a special place, or we had to use a special instrument or whatever. But we're going to take good care of you. Your course is going to be a little longer, but I'm going to be with you, and I'll help you more with that. And then the third phase, which I think is equally important, is a lot of times these patients will get distributed to somebody else. Like they'll go to retina, or they'll go to cornea or something. But you need to stay connected with those folks. It's your patient that is now over in retina and getting the lens retrieved, or whatever bad thing happened. And so I think it's very important that you stay with that patient and you help guide them through our ridiculously complicated medical system, because they're your patient. And I think if you do that, I think if you say you're sorry, if you communicate, look people in the eye, and if you help them as their guide through our complex system, that the chance of you having some sort of legal outcome from this is nearly zero. So anyway, that's my advice on that.
Dr. Oding, so the patient they have a complication, and they ask you, am I going to be okay? Am I going to go blind? What's next? How do you give them a prognosis at this stage so early?
Well, I think if it's something like this, something like Whitney's case or the case I just showed, it's highly likely that there's going to be no problem at all. And so I think the thing to say to them is exactly that their prognosis is spectacular, but their course is going to be a little different. They may have some more visits. They may have a little bit more care, a little bit more steroid, something like that. But I think that's an excellent point, is that we should also be reassuring about their prognosis.
Excellent, thank you. Dr. Yoganathan, can you think about some of the complications that you may have encountered? How do you document that in the operating report? Do you literally say everything that happened, or are you able to, or do you use certain words to make sure that it doesn't become a legal issue if discovered?
Sure, I think, let me just start by saying.
This question can go to everybody, actually.
Okay.
Yeah.
I didn't know if you said my name. I couldn't hear for a second. So is it okay that I
Yeah, go ahead, please.
Oh, okay, good. Okay. All right, Elizabeth Yu. I'm in private practice. I'm a cornea cataract refractive, and I take care of, a significant amount of pathology and tertiary level type cases, as well as a strongly refractive practice. Both of those yield really high maintenance patients, and whether it's a perceived complication or a true complication, both of those in the patient's mind, perception is reality, and so we have to figure out a way to really address that. I do think that being as honest as possible is key. Now, sometimes, just inadvertently, just because we are so busy, I'll just write a really quick thing, but generally speaking, those are the cases where instead of just using the normal template, I am using a dictaphone, and I want to make sure that I'm dictating. I'm totally open about saying I've done one wrong site surgery. By the grace of God, everything was similar between the two eyes, so it was fine. But do you understand how that shook me to my core? OMIC had me doing, jumping through hoops, and I was very honest with the patient's family. And I think that's what's really important is, one, you have to build this is my only major concern. I know that there's all sorts of different models in how we practice medicine, but not meeting the patients preoperatively and not building at least some level of a relationship or a connection with your patients. And some model systems have it where you're just going to meet them to operate, although that's more the minority. I have a major concern about that because the sincerity or your integrity, your work ethic, none of that comes through. They only meet you as the surgeon, right? And so, you're in the recovery room. If it's a simple complication, first thing, we have to know how to manage them. So be as adept as possible. And then even looking at like the ASCRS clinical survey, about a third of people who are graduating from residency, they don't feel comfortable managing like even a simple posterior capsular rupture with anterior vitrectomy. You have to know how to do those things. So get yourself versed so that you can think of plans A through F. And as Dr. Oeding said, you will be able to manage most of these complications where it's not going to equate to blindness. With that being said, I do say I did encounter a weakness. That is the one word I will use. That weakness is not a common one, yet it is something that is a complication. I did take care of it. And then I also proceed to tell them about the lens and the position of the lens. Generally speaking, it's going to still be in the same area. I'm often able to do an optic capture, but the biggest problem being that we just have to watch them in the postoperative period and making certain that we do emphasize the fact that if they have any of the signs that are concerning because of the increased incidence of having a retinal pathology secondary to having any kind of intraoperative complication. But that sincerity has to come through. You have to tell them in the postoperative recovery room, at least to the family, because the patient may not understand. And then I make certain, because a lot of my postoperative patients, I do about 30 surgeries in a day, so on that next day, I'm not able to see all my patients. I see my corneas, but my routine phacos I generally don't. But I make sure that they are on my schedule and that I carve out that time to sit with them face to face and let them know what's happening. And it doesn't have to be where you're down about it. You don't have to be despondent about it, but be honest.
Great, thank you.
I think in retina, you have an opportunity to set up expectations ahead of the OR. So in the clinic, the patient, oftentimes is not having bilateral surgery, doesn't have a lot of friends in the same situation who had cataracts, who had refractive surgery, where they have the comparison. So I think it's important to make the patient understand that every case is unique. A trauma case is different from a diabetic case, is different from a retinal detachment, is different from a 20/40 macular hole or epiretinal membrane. So I think during my consent process, and James Chalmers was a resident where I taught in Buffalo, and so we have a very lengthy consent process to make sure the patient understands all the different things that could happen before surgery, during surgery, and after surgery. So I think that setting up that expectation is really important for any surgery, setting expectations so that they know all the different permutations that can come after surgery. During surgery, I think it's important to set up certain behaviors in the OR. If the assistant doesn't give me the right tool, I never swear, I don't throw things, I don't get upset, I don't go crazy. In general, I think it happens quite often. Someone is tripping over the wire to the vitrectomy machine and it unplugs and the whole thing resets, and someone inevitably swears a little or says "oh no" or something like that. And during that time, you have to remember these are longer cases, about at least an hour or almost an hour plus for a lot of retina cases. And it's important to keep the patient informed. They're awake, they're listening to everything. They can imagine all kinds of things that could be happening in the OR while you're operating on them. And if they hear the resident ask a weird question, they're going to be sitting there much more nervous during the OR, and you definitely need to address that with them and their family when you leave the OR. I always talk to the family after every case, explain what happened, and to get back to your question, which was how do you document complications during the surgery? How do you tell the family? I'm definitely upfront with the family. If I say, the retina was really hard to reattach, the holes, the ILM was really hard to peel. I give them these little tidbits so that, again, to set up expectations for after surgery. In terms of documentation, to not get yourself, to not really be upfront about, maybe you rip this or you cause an extra tear. I do document these things because I think it's important when you're following the patient after, if they do have a redetachment, you're trying to figure out why did that happen, and maybe you thought there was an additional tear during surgery. So I draw procedure notes for every case. I dictate and I draw a procedure note, colored drawings. I think it's very helpful for teaching the residents and fellows. I think it's a good habit to have. And when I look at this picture, I remember everything about the case. I remember what we did and what the vitreous was like and all this. And so I may denote something in the procedure note that allows me to understand what happened post-operatively.
Thank you. I want to remind everyone that this is interactive. So if you have any questions for the panel, please raise your hand. We have a Starbucks card for the first person who has the first question. I saw one here. I'm sorry. All right. We'll come over here. Also, if you want to anonymously, or not anonymously, send in your questions, you can go to the mobile meeting guide. And on the mobile meeting guide, go to the YO program. On the YO program, you'll have an opportunity. There's a button to download what you need to ask a question, and it'll pop up on one of our iPads, so we'll be able to ask it that way. Congratulations. And this is a really cool Starbucks card. It's got Braille on it. Mm-hmm. I think it says Starbucks. Oh.
I don't know, Brad.
Thank you very much for that. I'm from the UK, and generally during a complication, we increase the level of anesthesia during the operation. What's your views on this with regards to performing a anterior vitrectomy?
I totally agree. I mean, it depends on the patient, but it goes from being a more routine case, and you're going to be calling out things, and they may sense the anxiety in your voice, and keeping our patients as comfortable as possible for the duration of the surgery is important. So if it looks like it's someone who cannot tolerate something deeper, I mean, my CRNA knows, because if I do this, I need them down, is what it means, and I can be like, I need them down maybe 5 minutes longer or something like that. We have like little hand signals in that regards. But if it's someone who can't tolerate the anesthesia because of their ASA level, then I will say, I think, would a block be warranted in this case, because it's going to take me maybe another 15, 20 minutes. So yes, absolutely, I agree with you. You want to make the patients as comfortable as possible and as cooperative as possible.
I just had this flashback to this case years ago where we had a lot of posterior pressure, and so I was talking to our resident about we were talking about the differential of the posterior pressure, and unfortunately we mentioned the possibility of aqueous misdirection, or malignant glaucoma is what we used to call it. And I didn't think anything about it. That discussion just didn't enter my mind at all. The case went fine. And then like a month later, this guy comes into the room, he closes the door, and he says, "Doctor, when are you going to tell me about the malignancy?" And then so this guy had been thinking about it for a month, that he had some cancer that we were talking about. And so it just reinforced with me how this communication is they're listening to everything that's going on in the room, how the tone changes in the room, all that kind of stuff is very critical. And so that's one of the reasons why you just have to be honest with them. You just have to. It'll also take some tension off of you if you just say to the patient, that something's happening and we're going to take good care of it, you're safe. It'll calm you down a little bit too.
I think both from the ethical standpoint, one of the other hats I wear is serving with OMIC. From the malpractice standpoint, it's incredibly important that you keep your credibility. And the way you do that is just to be completely honest with patients. You don't need to tell them every bloody detail that happened, because most of the time they don't want to hear that. But the moment they think that you're trying to hide something from them, you've lost credibility, and then it all tends to go downhill from there. And then they don't believe anything you say. So trying to maintain this attitude with the patients that I am here to help you. The reason I am here is to try to make you better. And as long as they believe that, they'll do almost anything you ask them. But the minute you lose that credibility, you're lost.
So I've heard some young ophthalmologists say, I look young, they don't really believe in my skills right now. Maybe I need to not talk about some of the challenge that they had in the operating room so they don't second guess my ability. What would you say to that young ophthalmologist?
I think if you talk with confidence, I think you can try to overcome, if you look young, being female oftentimes makes the patient question, your experience or ability as a surgeon. I think that's something that we all face. And I think the one thing I do hear from patients or residents or co-faculty is that when I speak, I'll say it with confidence, even if I'm saying something bad, and I think that's helpful.
Great. We got a question here. Tell us where you're from.
Hi, I'm Daniel. I'm a third-year resident in Arizona. I want to commend Whitney on a great video. And I wanted to also ask, I work primarily at the VA doing cataract surgery, and I've had maybe one or two cases where I had just a small buttonhole PC tear, didn't extend, no vitreous, put the one-piece lens in just fine. And usually what I tell the patient afterwards is something like, when we were taking out your lens, we found a tiny little hole in the back where the lens normally sits, didn't see any damage, put the new lens in just fine. And I know technically it is considered a complication, but patient's visual outcome was excellent. Again, like you were saying, Dr. Oding, that most of the patients will do just fine in that. I feel like if I'm going to say, there was a big complication, there was a problem, then I don't want to get the patient nervous. And I want to know whether to balance that. And I was wondering if you could comment on that. And thank you in advance.
Well, I hear what you're saying. I mean, what you're saying is that this is a little complication, and why bring it up? And it's got no significance at all. You could argue you save the patient and the federal government $500 on the YAG. So that's good. I do think there are some very small, let's say you had a radial tear that didn't extend. Let's say that Whitney's radial tear didn't extend. The lens is in perfect position. So there's a radial tear. Who cares? The lens is going to stay. We've so much data that lens will stay perfect forever. I still might mention it because a subsequent ophthalmologist might mention it. I still might mention that little hole because a subsequent ophthalmologist might mention it. But I might not put it in the operative note. I might not mention it to the QI committee. I would, but my focus is on that patient and them for the stuff that Ron's talking about. Sort of my relationships with the patient. So I think in that situation you could easily argue that it's enough inconsequential that it doesn't matter. But for radial tear, I probably would mention it because of that. But that's a good question. I did think a little bit about Whitney's case, about whether she could have just left it. I'm sure we were all wondering that. Could she have just left that lens with the radial tear and the posterior tear, but it was in position? But I think if you would have left it, if she would have made the decision to leave it, I think it's an important discussion with the patient because we're wondering if it's going to stay stable forever. And you could say, let's say Whitney just made the decision to leave that lens, not do the exchange, but she knew she had the radial and posterior tear, and she's thinking probably 95% chance that lens is going to be fine. You could say, let's have a discussion with the patient because we're doing this together now. We've got a new sort of course. And our course is we're watching the lens. That's the new game. And if it doesn't seem stable, then we might have to do the exchange later. So that's another option that Whitney had was really good communication, leave the lens, roll the dice, let's see what happens. So anyway.
Dr. Pelton, so a small tear occurs in any of these situations in anterior segment or in retina, something happens. Do you say, is there a way to word it? A tear was observed, or a tear was encountered, or do you say a tear was created? Does it matter?
I don't think it matters so much how you word it. Whatever wording seems to make sense to the patient. And realize, too, that if you were explaining this to another physician, you'd use different wording than if you were explaining it to like a homeless person with very little education. I think, again, the most important thing is just to be as completely honest as you can and to let the patients know. What I do is oculoplastics, they see everything that I do. I mean, they see it with their eyes. And I'll come in to see the patient post-op, and one side looks fantastic, and the other side is massively bruised and swollen. And I can see by the look on their face that they're unhappy. And the first thing I say is, that looks terrible. My God. And you just see this look of relief. They're like, thank God you think so too. So that sets the stage right there. I'm like, well, I've seen this many times. I know how to fix this. And I think it's the same thing with the cataract surgery, the retina surgery. Most of the things that occur with you guys have occurred before, and you know how to deal with it. And I tell them, it's like you're the captain of the ship and you're sailing out on the ocean and a storm comes. It's not the first storm you've ever seen. We know how to handle the ship. So as long as you project, as young as you look, as long as you project that confidence that I've been here before, you're in good hands, I'll take good care of you, they'll be happy with that.
Excellent advice. Last question, anyone else? Okay. Yes.
Hi, I'm Julie from Kansas City. I was just curious, going back to the preoperative phase, how are you guys telling patients about complications that could happen? Because I know I'm at the VA right now, and I tell every patient about the possibility of a posterior capsule tear, just because we have, you know, a lot of different people doing maybe surgery for the first time. So I wanted to get your input of how to tell the patient about complications in the preoperative phase.
So for me, it's a little bit depends on especially what technology that I'm using, you know, but the basic is always the same. Cataract surgery will take an average of so-and-so. The overwhelming probabilities you will do very, very well, and then you will use drops for about a month after surgery, and everything will settle in, you will heal fine. There are things that can happen, very unlikely, but that can include infection, which is between 1 in 1,000 to 1 in 1,500 in our clinic. It may be that you need another surgery, or your surgery may take longer than expected, of which we will do everything to manage it, but it still may need another surgery. Now, let me just assure you those chances are very, very unlikely, and it is because I must give you full disclosure of all the risks and the benefits. But there is an overwhelming majority of the cases, there's a great chance you will do just fine, you know. And then then the little bit, if they're getting a presbyopia correcting lens option, that I won't be able to do that. Would you like to be distance or near, you know?
Thank you, panelists. Thank you.
All right, we did it.